Hello. I'd like to thank Dr. Chung and the course organizers for the opportunity to speak on this topic. It's near and dear to my heart, and that's the endoscopic approaches to the management of obesity. Here are my disclosures. Um, I work with most companies, so hopefully they'll cancel each other out. So, endoscopic, bariatric, and metabolic therapies, or EBMTs, can be broadly classified into two categories: the gastric devices and the small bowel devices. And the gastric devices are seen here. There's space-occupying devices like intragastric balloons, and there's various types. There are gastric remodeling procedures that require the use of different devices to kind of plicate or suture the stomach together. There are devices that kind of obstruct the gastric outlet a little bit, and now procedures targeting that as well. And there are aspiration therapy devices. And these devices focus primarily on weight loss, first and foremost. They treat obesity. Then they do have secondary effects on metabolic conditions or comorbidities associated with obesity. And we also have small bowel devices, which these really focus primarily on metabolic conditions up front and first, and might not even be associated with any weight loss. So it's kind of interesting, right? And these include liners or sleeves that kind of shelter the duodenum from seeing any nutrients. Duodenal mucosal resurfacing, and there's different technologies here too. We won't get into all of them, but there's several companies focusing on how to work on this area. And then there's flow altering devices as well. And then there are revisional procedures, transoral outlet reduction and sleeve and sleeve. So these are for failed gastric bypass and sleeve gastrectomy. There's a recent document that came out. This is a joint society guideline from the ASGE and the ESGE looking at these therapies specifically. And our group was active in the process, but this is really a very international group of doctors that were called on to do this. And they use the GRADE methodology. And the first recommendation here is that in adults with overweight obesity, the guidelines suggest the use of EBMTs plus lifestyle management over lifestyle management alone for patients with a body mass index of over 30, with or without a comorbidity, or a body mass index of greater than 27 with at least one comorbidity. So this changes a lot of things that the kind of prior guidelines were saying about having the body mass index be at least 30. So clearly, this is new, and this is conditional with very low quality of evidence, but it is the current guideline. So starting with space occupying devices, these are various intragastric balloons, and several are approved by the FDA. And they include gas-filled balloons, fluid-filled balloons, balloons that you can pass without an endoscope, adjustable balloons that you can, if someone is struggling, they're not losing enough weight, you can make it bigger. If they're vomiting, you can make it smaller, and some balloons that pass on their own. So there's no endoscopy required at all. And then this is a space-occupying device that also includes the pylorus, so it's a little bit flow-altering, a little bit gastric outlet obstruction. So here are the balloons that are approved by the FDA, right? So we have the gas-filled balloons, the fluid-filled balloon, and the adjustable balloon. This one's approved but not commercialized, and this one is in trials, just about approved. This one that passes on its own. So these are all the balloons that really you may be able to see in the United States or get your hands on in a post-approval study or something like that. But these are the ones that are commercialized, and primarily the two that are most widely used are here, the adjustable and the fluid-filled. According to the FDA, the indication was class 1 obesity. So that's, again, a BMI of 30 to 35 here with associated comorbidity, or class 2 without. But now, again, the guideline says you actually can go all the way down to 27 for these. The main thing to keep in mind here is the contraindications, because balloons can kill people, and they do, right? And they cause gastric perforations, which are horrific. And the way to avoid that is don't put this in someone with a history of prior gastric surgery. Anything, even a Nissen fundoplication, you cannot use a balloon. And a very large hernia as well is very dangerous. So as long as you avoid these things, they're very, very safe. But in someone with prior surgery, you do run the risk of hurting them substantially. So you got to be careful with patient selection. So this is a meta-analysis looking at 17 studies over 1,600 patients. And they found that the total weight loss at 12 months was 11.27%. And it's several big studies there. And what was interesting is that percent total weight loss was consistent across all BMI categories. So down on the x-axis here, you have BMI starting down here all the way down 24.55. South America, they sometimes go pretty low, all the way up to 73 and they still lose about 12% total weight loss across the board. This is an interesting study that we did as a meta-analysis looking at 10 RCTs and 30 observational studies over 5,600 patients. And we were looking at comorbidity resolution with balloons. And here you can see overall the HbA1c decreased by 0.6%. But if you look at the studies where the baseline HbA1c was greater than 6.5, so they clearly had issues with glucose homeostasis, they had a 1.1% reduction in A1c. So that's substantial. That's like a good anti-diabetic medication. So balloons do have a secondary kind of effect on diabetes. Waist circumference improves, LFTs, hypertension, dyslipidemia, all improve with statistical significance across this meta-analysis. Now, again, the SAE rate, this is not insignificant, a 1.3% SAE rate with 5 gastric perforations and 2 deaths for a mortality rate of 0.04%, and both those patients had prior surgery, should not have gotten a balloon. What about long-term results? Not so favorable, okay? So this is a prospective open-label study of 500 patients with 5-year follow-up, all right? They had excluded 26 patients because they basically had protocol violations, and another 17% didn't have initial success. So this is long-term follow-up on success, people that were initially successful with the balloon. So again, they eliminated about 18% of people here. And then if you look at those people that were successful and you follow them for 5 years, only 20% maintained 20% excess weight loss, or about a 10% total weight loss at 5 years. So not great long-term result, right? This is a small number. So you need a plan. If you're using a balloon, you need a plan to make sure they really can keep up with lifestyle modification, or maybe you're going to, give them medicines afterwards. So you got to wonder what the long-term game plan is there. Again, back to our guideline. So they also looked at balloons, and the guidelines suggest the use of the balloon plus lifestyle modification over lifestyle modification alone for sure. And they also suggest the use of antiemetics, because there's a lot of nausea after this, use of pain medications peri-procedurally, as well as the use of PPIs before and after until removal. Again, conditional with moderate evidence, and then very low for the PPIs and pain meds. Moving on to gastric remodeling. So early on, there were 2 kind of surgical analogs that were being considered when we were trying to design these procedures. One was the VBG, and this was pursued by Roberto Fogel in Venezuela. And the other was the gastric imbrication procedure. So this is early 2000s. And Bard actually was a company that pioneered much of this, even though they got out of the business decades ago. They were the ones that were really paying to develop these procedures early on. So this was the original Bard device. Again, they no longer have any endoscopic equipment even, but they sponsored this initial trial with us in the Cleveland Clinic, and this is the exact same pattern we actually use for ESG. So the early ESGs. So it's a gastric kind of greater curvature procedure where we place a stitch on the anterior surface of the stomach, greater curve posterior, move back and repeat. And we keep doing running sutures to get that beautiful tight sleeve-like appearance at the end. So it's quite nice. And we'll show that again. So that'll loop. But so this is a prospective series of 18 patients. And we had a 27% excess weight loss. That's 30% total weight loss, which you'll find out that's the same amount of weight loss we actually got in the MERIT study, right? The big randomized controlled trial that approved the current ESG. But the company made surgical devices, so they weren't happy with this because this is less weight than you get with surgery. So they ended up just dissolving the program, unfortunately. And it might not have been for bad reasons here. So again, you can see the tight sleeve again. You saw improvement in all the other, metabolic indicators here, blood pressure and everything else. But the problem was at 1 year, a lot of those sutures were falling out. And there were no adverse events, and all these subjective measures were better. But the fact that stitches were falling out was concerning. And it's probably because this is not a full thickness suturing device. We were placing the stitches really in the submucosal space. So then in 2012, myself and Rob Hawes, he helped develop this device, and I developed the procedure. We did the first in human ESGs with the current overstitch device. This is Gen 2. So, and we presented this, actually we did one of the cases live. This was the live broadcast case in India. So the first several cases were done in India in 2012, and then we moved to Dominican Republic and Panama. So we did a kind of an international pilot study, if you will, of 126 patients. And you can see the body mass index dropped from 36.2 down to 29.8, which was a good drop, falling out of the obesity range. And that was a 19.5% total weight loss. So that's fantastic. And that's what we got with full thickness versus partial thickness. Then Reem Shirai down at Cornell did some really great work. This is a single-center retrospective study of over 200 patients. And she followed them out for 5 years. And she found that, they maintained a 15.9% total weight loss at 5 years. So that's really encouraging, right? And only 27% of people had any pharmacotherapy. And GLP-1s weren't even available then. So you're like maybe having some of them on phentermine or something. There was a 1.3% adverse event rate or SAE rate. I think one person had a leak that required a drain in her series. And then this is the big RCT. Now, this is a little problematic. So they changed the suturing pattern for this. We were part of it too, but they changed the suturing pattern to one that's probably not as good as the one we've been using in all those other studies. Additionally, we did it during COVID where people couldn't get to the gym. So there were some issues. And we got a 13.6% total weight loss here at 1 year. But still, this was good enough because the control group, had almost no weight loss at all here at 0.8%. So clearly that was significant. And it got FDA approval for de novo marketing authorization. So this is an approved procedure now. And so it is being more widely used. This is a meta-analysis looking at 8 studies, over 1,700 patients, 16.5% total weight loss at 1 year. So this is probably a safe number to quote if you're doing these procedures. Serious adverse event rate, about 2%, and the leak's the thing you worry about. The more you do, the better you get. Avoid the fundus, and there's all sorts of tips we'll talk about. So this is the current suture pattern. We all gravitated back towards to get back to that 19% total weight loss, which isn't far from a sleeve gastrectomy. And we use a combination of running sutures, interrupted sutures, and these U sutures. And the idea is you're basically reducing the width of the stomach by bringing in that greater curve. But with these U's and you're moving proximal along the posterior surface of the stomach, you're actually shortening the length of the stomach substantially. A lot of times the stomach will be several centimeters shorter in length. And the idea is you want to delay gastric emptying. The mechanism here is delaying gastric emptying. And this is an effective way to do it. So this is the new pattern that we've been using for a few years now. It works very well. And the stitch principles we adhere to are using a helix for full thickness tissue stitch placement. You need to really get full thickness or the stitches fall out. You want to run the sutures very close together, at least less than 2 centimeters apart for sure. We target about 5 millimeters. Avoid crossing and locking of sutures. You won't be able to pull it tight at the end. And we want to avoid alpha loops and excessive tension. So this is what it looks like when you're suturing. And you can see that the stitches are very close together. They stack up quite nicely here. You see one stitch after another right there. And generally we're putting about 60 or 70 stitches in, and usually about 8 sutures. And so you can see how that kind of runs together. And then when you're done suturing a run of suture, you cinch. You don't have to tie knots. So this is a cinching device. So basically you're pulling the suture through the cylinder, and then there's a little plug that traps the suture and cuts it. And then we resume with another pattern here. So that was just a running suture to begin. You can see that's a neo-pylorus we've created. And then we do interrupted stitches. But I'll show you the next final appearance. So this is what it looks like when you're done. It's a nice tight little sleeve. Takes about 40 minutes. And the patients do quite well. So this is, again, back to our guideline. And you can see here the guidelines suggest treatment with ESG, or actually endoscopic gastric remodeling, because there's other devices that can do that are on the horizon, plus lifestyle modification over lifestyle modification alone for sure, and that's conditional and moderate. This is the same quality evidence you have for GLP-1s, by the way, so it's not bad, right? And then the rest is, basically peri-procedural care, and you have a lower quality evidence for the peri-procedural care, but they do suggest the antiemetics peri-procedurally, pain medications as needed, prophylactic, you definitely want antibiotics in this case, unlike with the balloons, and then PPIs as well, short-term around the procedure. So moving on to small bowel devices. So sleeves, dually mucosal resurfacing, flow altering. These have, again, stronger diabetic effects. Oh, actually, So we're not going to get into these. None of these, I'll mention them briefly, but none of these actually are approved by the FDA. So they're all in clinical trials, every single one of them. So this sleeve's in clinical trials, the ablations in clinical trials, et cetera. And they're working on foregut and hindgut mechanisms. So what's very interesting here is that just like GLP-1s, that's an incretin, right? It's released from L cells in the small bowel. The farther down the small bowel you go, the denser the L cells are, even in the colon. So, the best trigger of the recent GLP-1 is secondary bile acids, but you also can trigger those spikes in GLP-1 with other things. And the incretin effect is quite interesting. It's that you have a much stronger release of insulin in response to glucose when that glucose is given orally rather than intravenously. So that mechanism really shows us that a lot of these metabolic comorbidities are GI related. Okay, they're really intestinally related. So these new devices really are quite interesting. That's a topic of a whole other talk, but because they're not clinically available right now, you aren't doing them, we're not going to focus on it too much. But what about other things we can do clinically? Well, so this is another procedure. We published this recently in Gastro. And this is called the GEM procedure, gastroplasty with endoscopic myotomy. Since we know gastric balloons and ESG both work by delaying gastric emptying, there are other ways you can delay gastric emptying that might be more effective and less expensive, because you might be able to do these without a suturing device. So this is one thing we've been pioneering. And we studied 6 patients. We followed them for 6 months. They had a 19.5% total weight loss. But what we did here was, and you can see in this video, we did a myotomy of the antrum. So we basically made a long myotomy. We made a tunnel from the incisura to the pyloric ring. We did not cut the pyloric ring, left it intact. And then we do a long myotomy, about 15 centimeters in length, all the way back to the incisura. Then we close the tunnel. 100% of patients had at least a 10% total weight loss. What was interesting here in the gastric emptying breath test, the half-life for emptying went from 90 minutes to 204 minutes. So clearly a very consistent delay in emptying. So we were worried they might get symptoms of gastroparesis, but none of them did. Here we're doing a full thickness cut, by the way, and then we're going to suture. None of them actually did. So the GCSI scores remained stable with the exception of change in the postprandial fullness and early satiety subscale. So that's where we saw a change, which we wanted. We want them to get full earlier and stay full longer. So interesting how a myotomy can actually do that. Now, we did do a small abbreviated ESG in this case, but now we've modified this just to do the myotomy alone. And with that myotomy alone, we're getting as much weight loss as with the ESG in the MERIT trial. So that's something new, very affordable, very inexpensive, and something that is, we think, going to be, so the RCTs are finishing up right now, but you might see this clinically in the near future available. So here are other devices that are now available in the United States, actually. So, and they are FDA cleared. They don't have a weight loss indication, but you can use them. You just can't get trained and the company can't market it for weight loss. But this device is a plication device, as is this one. So they're a little different than the suturing platforms you've seen. They're a little easier to use, honestly. The learning curve is a lot quicker. You can do 6 plications with this platform, get the same amount of weight loss, about 18% total weight loss. I can't remember how many you do with this one, but they're very interesting. They're both available. We do actually offer both of these in our unit now. We do more of the suturing, though. And this one is from Israel. This is not available yet, but this is automated. So you actually just place it into the stomach, you push a button, and it suctions the tissue in and places the plications for you. So it's fully automated. Literally, just push a button, and then you come out and repeat. So it's getting very, very interesting now, this space. You can see how the tissue is kind of being plicated together there. So what about weight regain? This is a very common issue. Recurrence of weight gain, many different terms for this, but someone has a gastric bypass or a sleeve gastrectomy and they've regained their weight. Okay, you could just go down the rabbit hole of more and more surgery, but we can actually offer more endoscopically. So obesity is complex, multifactorial, and we don't really understand why people gain weight because we don't understand why they lose it from the surgery in the first place. But there's a few things we have to make sure. We have to double check the dietary noncompliance. We want to make sure they're compliant with the diet and exercise. We check for thyroid disease, iron deficient anemia, hormonal changes, things like that. But then if you've excluded all that, you have to consider anatomic issues like a dilated anastomosis for gastric bypass patients or a dilated sleeve. So this was a study we did years ago, again, using the old BARD equipment when they were still in the game. And it was a randomized sham-controlled trial and a double-blind, so very rigorous study. And we had patients that regained weight after gastric bypass, and they were randomized to either get a sham procedure or a transoral outlet reduction called a TOR procedure. All right, it was 27 and 50, so 2-to-1 randomization. And you can see we did an intent to treat analysis. Both groups lost the same amount of weight while they were on the liquid diet for 6 weeks. But then when they liberalized the diet, the control group, the sham, put their weight right back on, and then the treatment group kept their weight off. Then at 6 months, they crossed over. So this was a very good early efficacy signal, but only about a 3.5% total weight loss, again, because it was a superficial suturing device. It wasn't doing full thickness suturing. But again, it was statistically significant, provided level 1 evidence that this mechanism is something that might be effective. So then when we got the new suturing device, we were able to put full thickness sutures in and actually change the pattern to a purse string pattern. So here we studied 331 patients. We did a 5-year follow-up, and they had an 8.8% total weight loss. So very impressive, actually. So now this actually 10-year results, it's still above 8% total weight loss at 10 years. We presented that at DDW. So very exciting. And this is good. And if you compare this to surgery, it's the same amount of weight loss. There's no difference. So you're getting the same amount of weight loss as a surgical procedure. So this is a MASH cohort study looking at 62 patients that had weight gain, and 31 had surgery, 31 had TOR. And the only thing that was different is the severe adverse event rate. And there was no one in the endoscopic arm that had a complication, but there was 19.4% in the surgical group that had very serious life-altering complications. So this is a great procedure. Insurance companies love to cover this too. But you don't stop. We keep getting better. So now we have a procedure that actually does better than surgery. We're getting substantially more weight loss than surgery in revising gastric bypass. And this is called the TOR Plus or the ESD TOR. There's different names for it out there. But what we're doing is we're cutting. So the mucosa doesn't want to stick to itself. That's the main thing it doesn't do, right? Otherwise, you'd go to sleep and wake up in the morning, you couldn't open your mouth, right? So the mucosa doesn't stick to itself. So it's really hard to suture it and get it to stick to itself. So what we're doing here is we're cutting a channel, a little incision, making an incision circumferentially around that gastroduodenal anastomosis, as you can see here, so we can sew right in the muscle. And then we're doing a purse string suture around this. We'll ablate this intervening mucosa with APC, 70-watt forced APC. And then, after that, we will run a purse string suture in this tissue. And now instead of getting 8% total weight loss, we're getting at 1 year 12% total weight loss, which is more than surgery. So very encouraging. Our SAE rate didn't change at all, and this is kind of really, I think, where we're headed. So we have to think more about tissue preparation, even in primary bariatric therapies, when we're starting to think about getting greater weight loss and more durable results. And so this is what the purse string suture looks like in the video. Basically, you're plicating the tissue to the tissue that's directly adjacent to it. And then when you get halfway through, you're going to flip the device and continue. On average, you place 15 stitches into one of these outlets. I'm only showing a few of them in the interest of time. And then what you're going to do is size it over a balloon. So this balloon is probably about an 8mm balloon. And then you'll have a nice new outlet there that is going to be very durable. So for sleeve revision, so patients with a dilated sleeve gastrectomy, I feel like we have an epidemic of this right now. This was a big multinational retrospective study, including our center and others in Brazil. And it was just the first time it was done. So it was a small number of patients, 34 patients with sleeve gastrectomy. And we basically did a very similar pattern to what you see with ESG and got an 18% total weight loss. So that was encouraging. We now have a series from our hospital alone. Dr. Giarpino was lead author on this, and it's a retrospective cohort study comparing our endoscopic sleeve patients, 70 of them, to the surgical revision of sleeve gastrectomy patients. So in this they're combining both the patients that are re-sleeve as well as a conversion to gastric bypass. And there were 83 patients, just head-to-head. Baseline characteristics were similar. And you can see here the weight loss at 12 months was very similar between our endoscopic group and the surgical group. There's no substantial difference, but the SAE rate again is where endoscopy shines, with 13% very serious complications in the surgical group and no complications in the endoscopic group. And finally, what about new technology? Well, this is a robot we have in our lab right now. Actually, this is the old robot. The new one's very pretty, but this is an old robot, and we have a new one. And we're doing ESG with this robot. We're also doing endoscopic submucosal dissection with it. And what we're finding is people learn really quick on the robot. So this is going to shorten the learning curve. Additionally, it might be less expensive using the robot because this is all reusable, sterilizable equipment. So you don't have to buy an expensive suturing device. So this is very very exciting, the potential here to have a reproducible kind of very efficient procedure that you can do maybe a little quicker and have a shorter learning curve for docs out in practice already. And this is a simulator that teaches you how to use it. So it's like a video game. So basically, ultimately what the company will do is send this to the doctors, have them practice on this until they get to a certain minimum score on these little activities, and then you're able to do the procedures. So it's kind of neat. So just a new way to train people that are already in clinical practice that might want to get involved in these procedures, whether it be submucosal dissection, like ESD or weight loss procedures. So in conclusion, endobariatrics has a clear place in the spectrum of obesity management. Clearly you're getting a little more weight loss. And actually, there's a new study I should have mentioned that we published in JAMA Network Meta that basically showed that the endoscopic procedures were cost effective compared to the medications. And for medications to be competitive and actually not be dominated, the medications would have to really drop their current ASP threefold. So it's really hard for them to do that currently. So we really do have a place, not only from a little bit more weight loss and durability, but the fact that it's potentially more cost effective compared to the meds. A lot of patients also tried the meds and didn't tolerate them, and this is a nice way to have something to offer them. So endobariatrics does have a clear place in the spectrum of obesity management. New technology and combination therapies are on the horizon. So if you combine a GLP-1 with these, now all of a sudden you get surgical quality kind of weight loss. And we must now focus on training and credentialing issues to make these more widely available. Thank you very much for your attention.